great honor for me to be attending in today's morning report. Actually, it's our first English morning report. First, I gotta thank Educational Deputy of Children's Medical Center, Pediatric Center of Excellence for letting me host this event. And actually, today's morning report is being held by IMA Association. IMA, AYMA, which stands for Allied Young Medics Association, is a newly based association here, and I'm Sevil Abdul Mohammedia, third year pediatrics resident and in charge of educational department of IMA, along with my friend Dr. Bakhtiari. We will run the educational department of it. So I believe each and every one of you want to know what's going on there. There are a lot happening there, so let's enjoy the clip and you will find out soon.
Okay. I think everyone has my voice. Good morning, everyone. I'm Dr. Mariam Bakhtiari. I'm a third year pediatric resident here in Children Medical Center, and I have the honor to be here with you guys in this spectacular event held by IMA Association from Pediatric Center of Excellence. As you can see, I'm burning with excitation, so I'm sorry for the vibration in my voice. I hope you enjoyed this video clip as much as we've enjoyed preparing it for you. And I have to especially thank my dear friend, Dr. Aylar Ahangari, for all of her efforts to prepare this clip for us, and also for all of her amazing contributions to IMA as a vital member of our group. So, as you might have already guessed, after watching our clip, IMA is a new association based in Pediatric Center of Excellence. Our main focus is providing educational content and opportunities to grow our network in Iran and internationally, to learn from the best of the field and leading scientists, and also to share our own knowledge and unique perspective with others. Because face it, in Tehran University of Medical Sciences, we are awesome. We also provide research opportunities for young researchers, starting from workshops to amazing scientific projects and papers. We can't wait to meet you. We are actually recruiting members for IMA from medical students, interns, and residents. Don't hesitate to contact us for more information. We believe that the sky is our only limit. Let's get our voices heard and let's shine with IMA. As you can see, I'm really excited, but I'm not going to take any more time from our session, and we're going to start with our first case. Okay, so our first presentation is going to be with My friend is going to do it. My friend, Dr. Mahsa Khezri, a first-year pediatric resident. So, Dr. Khezri, if you can hear me, you're waiting for your presentation.
Of course, Dr. Bakhtiari, thank you. Now I will share my case. I'm trying to share it. It's okay. Can you see the slides? Can you please? Okay, never mind. Hello, everybody. Good morning. My name is Mahsa Khezri, and I'm a first-year pediatric resident here in Children's Medical Center at Tehran University. I'm going to present for you the first case, which is a toddler with a skin rash and generalized erythema. Our patient is a 16-month-old toddler with a skin rash on the cheeks, neck, and trunk. He had circumural erythema around the eyes, mouth, and nose 1 day prior to admission. 3 days before the onset of the rash, he complained of fever and malaise and skin tenderness. 1 week ago, he had a blister under his right toe while toddling and by stepping on a foreign body by accident. The blister was ruptured and infected. It had discharge that he received outpatient medication, included cefixime and ibuprofen for 4 days. In our past medical history, as we asked the mother, she didn't mention any significant past medical history. The toddler was not admitted till now. He was third child with 39 weeks gestational age, elective cesarean section, and no birth insult. The drug history, as I mentioned above, was ibuprofen and cefixime. We asked for food allergy, drug allergy, but it was negative. On our physical examination, the toddler was awake and restless, no respiratory distress. The temperature was 37, pulse rate 125, blood pressure 19/60, respiratory rate 25, with 98% saturation in room A. In our head and neck physical examination, we saw bilateral non-purulent conjunctivitis. He had circumural erythema with crusting and fissuring around the eyes, mouth, and nose. I mentioned it above. He had diaper rash, no lymphadenopathy, and Nikolsky sign positive. Heart and lung auscultation were normal. Abdominal examination was also normal. And in the extremities, we saw the crusted wound under the right toe and no discharge. In our laboratory data, the white blood cell count was around 16,000 with 61% lymphocytes, 31% neutrophils, and hemoglobin 11.8 with 568 platelets. The estimated sedimation rate, or ESR, was 4. C-reactive protein, CRP, was 3. The biochemistry were normal. I won't bother you by reading them one by one. Urine analysis was normal, and urine culture was negative. In our management, we hydrated the toddler, of course. We managed the pain with painkillers. We started antibiotic therapy with chlorhexidine and clindamycin. We gave him sterile shades for wound care and contact isolation, and we used topical Eucerin. You can see the picture. Here's the infected wound under his right toe. Here's the erythema, the circumural erythema around the mouth, on the cheeks, on the neck. Here's the face overally, on his hand, upper extremity, and the toddler overally sitting on the bed. In this summary, we have had a 16-month-old toddler with a skin rash and generalized erythema, more in flexural and periorificial areas with crusting and fissuring. He complained from fever, malaise, irritability, and skin tenderness, and he had an infected blister 1 week before the skin rash and admission. That was the end of my presentation. Thank you, everybody, for listening and paying attention. If you have any question,
Thank you, Dr. Khezi, for your great patient presentation and also your great slides. So I'm going to ask our dear Assistant Chief Resident from the shift. So Dr. Nasri, my dear friend, a second year pediatric resident here. So, so Dr. Nasri, could you please, sorry, no, wait. Okay, so so, Dr. Nasri, please go on with the differential diagnosis and also tell us what you did for this patient. Thank you.
Hello, dear participants. I'm Dr. Nasri, second year resident of pediatrics. As Dr. Khazri explained, the patient is a 16-month-old boy who 1 week after injuring his leg by a foreign body developed fever and erythematous skin lesions, which were initially on the neck, thighs, legs, and arms, and then periorificial areas involvement occurred. The patient also has a history of taking ibuprofen and cefixime in the last week. Given all the conditions, our first differential diagnosis is for S disease. Other differential diagnoses are ruled out by the shape and extent of the lesions, as well as the lack of involvement of the oral mucosa and history of drug ingestion and Mikulski sign. And actually, we started treatment with hydration, pain management, and antibiotic therapy with semi-synthetic staphylococcal penicillin and clindamycin. Clindamycin is typically used to inhibit bacterial protein synthesis, also toxin synthesis, and we should add it to, for example, cloxacillin. Also, the skin should be gently moistened and cleansed. Application of the emollient provides lubrication and decreases discomfort. Topical antibiotics are unnecessary. If you have any question, I'm here. Thank you.
Okay, so thank you, Dr. Nasri, for explaining the patient and also wrapping it for us. So I'm going to start by asking our professors for sharing their knowledge with us. Just before starting this, I forgot actually to say this before. We are going to take a group picture at the end of this morning report as a gift, as a remembrance for all of us. So please make yourself decent, and we are going to take a group photo at the end of this. So have this in mind. Okay. So I'm going to start with our infectious professor. So Dr. Ishaqi, can you hear me?
Hello.
Hi, Dr. Ishaqi. Good morning.
Hello, everybody, and good morning. And thanks for your nice program.
Thank you. So, Dr. Ishaqi, we had a question because the patient that we are having is actually, it seems like the main diagnosis that we have for this patient is 4S. So would you mind to guide us through the antibiotic regimen that we prefer in these patients, and also the duration of treatment, and also all this stuff around the antibiotic? Like, do we have to give all of them IV antibiotic, or can we follow them at home with oral medication?
Of course, in considering that 4S is caused by an Staphylococcus producing epidermolytic toxin, the treatment is focused on eradication of Staphylococcus infection foci, either as a normal flora or as a pathogen-inducing local infection. So the most commonly used drugs for this reason is penicillin-resistant anti-staphylococcal penicillins, such as methicillin groups, and first and second generation cephalosporin as the alternative treatment. However, some experts believe that or advise on administration of clindamycin with cloxacillin, for example, and they believe that these accelerate the onset of healing process. That's exactly what we are doing in our centers. But honestly, I have to say that there are several studies that, or several comparative studies between two groups of patients that treated with and without conjunction clindamycin, in all of them, there were not any significant difference between clinical course and outcome and sequel, or even stay length, hospital's length of stay. And on the other hand, there are several studies that show the clindamycin resistance of aureus are more prevalent than cloxacillin resistant pathogen in this disease. Based on this fact, I think we have to reevaluate and reconsider our antibiotic plan in forest disease treatment.
Thank you, Dr. Ishaqi. And also, I had another question about the lab tests that we need to perform in these patients. Do we need to obtain especially blood cultures or lesion cultures aside other biochemistry tests that we do in these patients? Do they have any value in these situations or not?
Yes, sorry, before answering this question, I forgot the last question, your last question was two portions. As the second part of your question, I have to say, as a rule, all of patients suspected or confirmed with forest disease have to hospitalize. Hospitalization seems necessary for starting the IV antibiotic as soon as possible, supplying supplement fluid therapy, correction of electrolyte imbalance, and preventing or treating the probable superimposed bacterial infection. It seems that the period of IV antibiotic therapy have to be 5 to 7 days. During the first days of the treatment, the fever subsides.
Dr. Ishaqi, I think we lost your voice.
Sorry, you have my voice?
Yes, now. Continue.
Yeah. And I lost my word. About IV antibiotic therapy. And after the 2 or 3 days after beginning of an IV antibiotic therapy, fever subsides, the rash begins to clear, and healing occurs within about 5 first days. And after that, you can discharge a patient, advised to continue oral antibiotic and close follow-up. A topical antibiotic, as mentioned Dr. Nasri, is not effective on treatment because we know that all of the blisters and skin lesions are sterile, and in fact the disease is an toxin-mediated disease, and is not due to direct invasion of Staphylococcus aureus. About your second question, in the diagnosis of the disease, as I said earlier, the disease is a toxin-mediated infection, this disorder, and then usually culture of blood or fluid blisters of lesion are negative. However, in critically ill children, we have take culture from any suspected area of infection, such as blood or local skin infection, to determine the infection, and also to determine the antibiotic susceptibility that can manage and ameliorate our antibiotic regimen. That's it.
Thank you, Dr. Ishaqi. It was great and
You're
also
welcome.
informative, and thank you for joining us again. So,
Welcome.
okay, so I'm going to ask our dear resident dermatologist, Professor Sotude. So, Dr. Sotude, if you can hear me, it's really an honor to have you with us today in this morning. We would really like for you to guide us through the differential diagnosis of such exfoliating disorders. And also, do you also, Dr. Ishaqi said that the topical treatments do not have any place in the treatment of these patients, but what is your opinion about this?
Hello, Dr. Bakhtiari. Can you hear me?
Yes, of course, loud and clear.
Good morning, everyone, and thank you all for inviting me to this exciting event. Could you please show us the pictures of the patient?
Yes, in a minute.
Because I want to describe the signs, the skin signs of the patient. So we need to have the pictures.
Yes, sorry. So just please scroll the slides to find the picture. Okay.
Thank you. The first picture is very, very good.
Is it okay?
Yes, and the next slide after that. As we see, this is a 1.5-year-old boy who has been admitted because of skin lesions and also the history of fever a few days before admission. On a skin exam, we see erythematous patches on the face, especially perioral area and periorbital areas are involved. There are also patches on the neck, on the upper trunk, and also on the flexural areas of the upper extremities. In the history of the patient, there is a history of a solitary blister on the plantar surface of the right toe, which is now appearing as a crusted lesion. And we were told that the Nikolsky sign has been positive. What is a Nikolsky sign? It means that when we induce a gentle pressure on the skin, it peels off easily, it comes off easily. The positive Nikolsky sign is very important in this patient because there are just a few diseases that the Nikolsky sign is positive. Another important point is in this patient is not involvement of the mucosal membranes. That's very important in differentiating from other exfoliating diseases. There is not any history of atopic dermatitis or allergic reaction. This is another important point in the history of the patient. Overall, I think all of us agree that the first and the best diagnosis for this baby is 4S or Staphylococcal scalded skin syndrome. As we know, 4S is a toxin-mediated reaction, so we cannot find the Staphylococcus directly on the skin. The Staphylococcus could be found in a far place like nasopharynx, conjunctiva, and probably in this patient, the bullous lesion on the toe has been the entry point of the Staphylococcus. And the exfoliative toxin has been spread through the blood all over the body and has reached the skin and has made the skin peeling. What are the important differential diagnoses? Actually, I think it depends on the stage of the disease that we see the patient. In very early stage, especially if the patient doesn't look very toxic or even afebrile, an allergic reaction or atopic-like dermatitis may be considered in the differential diagnosis. There are so many patients who have been referred to us as dermatologists with the diagnosis of an allergic reaction and the prescription of a topical steroids on their hands. And in complete exam, we have found that this is a case of 4S, especially when the Nikolsky sign is not positive in the early stage of the disease. and the patient doesn't look very toxic or doesn't have fever. But when the Nikolsky sign is positive, when we see the peeling of the skin or the exfoliation, the diagnoses are different. The most important differential diagnosis in this setting is toxic epidermal necrolysis, or TEN. TEN is a kind of drug reaction, especially drugs like anti-epileptic drugs. But the most important distinguishing feature in these patients is involvement of mucous membranes in toxic epidermal necrolysis. So when there is almost always there is involvement of mucous membranes, this is in favor of toxic epidermal necrolysis, but it absolutely rules out the diagnosis of forest. Another important differential diagnosis is epidermolysis bullosa. Sometimes we are consulted in neonatal ICU for neonates that we don't know if they have 4S or epidermolysis bullosa. Of course, epidermolysis bullosa is a mechanobullous genetic disorder, and bullous lesions are found primarily on parts of the skin that are exposed to trauma. And the course of the disease is a chronic course, not responding well to any kind of treatment. You asked about the place of topical treatment. Actually, the topical treatment does not help us so much. We just recommend sterile bed sheets and the sterile Vaseline gauze on the parts of skin that have been peeled off, and the topical emollient like Eucerin on the parts that have been healed. Topical steroids has no place in the topical steroid or topical antibiotic has no place in the treatment of these patients. I will be taking any questions if you have.
Thank you, Dr. Sotide, for your brief and informative lecture. So I see a question in the chat section. My dear friend, Dr. Samimi, has asked about the association between atopy and eczema with the severity of symptoms. So is there any relationship between this? Does any patient who has a predisposing factor like eczema or atopia will show severe signs, or no?
No, there is not any relationship between atopic dermatitis, but just atopic dermatitis could be the skin could be an entry point for the for the entry of Staphylococcus aureus. Staphylococcus aureus are found more on the skin of the patients with atopic dermatitis. But if the patient has atopic dermatitis, there is not any direct relationship with forest.
Thank you, Dr. Sotude, again. Thank you. So because we're a bit short on time, Dr. Kalantari, our dear immunologist, was also supposed to join us, but I can't see him in our list. So I'm going to ask Dr. Sharif Zadeh, our intensive care professor. So Dr. Sharif Zadeh, if you can hear us, so could you please guide us through the fluid and electrolyte management in these patients, and also the tips and tricks of ICU care in these patients? And if you could have like we have 5 minutes for your lecture, so if you can.
Okay, hello. Can you hear me?
Yes, of course, loud and clear.
Okay, hello dear colleague and dear professor. About the ICU management and the fluid and electrolyte management of the patient admitted with 4S in ICU. First, I must say that do all of the patient need ICU admission? All of patient, the answer is no. All of patient hello, do you hear me?
Of course. Yes.
Do you hear? Yes, yeah. Some indication is presented for the ICU admission of these patients. The most important indication for the admission of this patient in ICU is severe fluid and electrolyte disturbance, severe acid-base disturbance, and a toxic situation. About fluid and electrolyte, I must say that adequate hydration should be ensured and trauma to the skin should be minimized. This is the cornerstone of therapy of this patient. Prevention of dehydration is very important. Fluid loss through the skin can be significant in 4S, and many patients have decreased oral intake of fluid due to irritability, fatigue, and perioral pain. Intravenous hydration is very necessary to prevent dehydration and secondary electrolyte abnormalities. Application of maintenance fluid plus restoration of deficit and ongoing loss is mandatory. In the case of low intravascular volume and shock state, blues of crystalloid or colloid should be used, and standard care of shock state is the cornerstone of therapy, especially in acute phase. In acute phase, treatment of electrolyte imbalance such as hyponatremia and hypernatremia, hypo and hyperkalemia, hypocalcemia, or hypomagnesemia is very important. And there is an important issue about treatment of acid-base disturbance in ICU. In ICU, we are confronted of many children that are severe dehydrated, and the most important cause of dehydration of these patients is fatigue and irritability and oral ulcer that prevent the sufficient fluid uptake and food uptake in the previous days. This is about fluid and electrolyte, but ICU treatment is based on 7 basic axes that I emphasize on it. First, fluid and electrolyte therapy. Second, antibiotic therapy. I don't interfere because Professor Esali explained us. Third, pain management is very important before any intervention, before any skin care. We must use acetaminophen and morphine sulfate, and wound care is very important in this patient. Wound care in the 4th axis of treatment in ICU. And the 5th axis of care, skin care, bathing and dressing is very important for this patient. One of the most important treatment axis in ICU is airway management. Because of oversecretion, oral oversecretion of this patient, the breathing is difficult. All of these patients have nose ulcer, and some of these patients have intraoral ulcer that make breathing very difficult. Airway management is very important. Gentle suctioning and the hygiene of the oral is very important. And finally, 7th issue in ICU is temperature stability and temperature control. That is very important for these patients. I'm at your service.
Thank you, Dr. Shaifzadeh. Thank you, sir. Thank you for your great and informative and also to the point lecture. So thanks again for joining us. So
Thank you so
Dr.
much.
Kalantari, our dear immunologist, is also in the audience. So Dr. Kalantari, if you can hear us, because can you hear me actually, first of all? Dr. Kalantari.
Hello, dear Dr.
Hi, Dr. Kalantari.
Yes. I'm here by the name of Oscar Shirazi.
Yes, actually, so I couldn't find you first. Yes, sorry about that. So
I have a funny question.
Yes, okay, yes. So I see a question in the chat section about the corticosteroid and also the IVIG treatment in these patients. And also if you could tell us about the differentiation between contact dermatitis, drug eruptions, and also 4S. Also, although Dr. Sotude explained about these, but also if it would be great if you could hear your input as well. And also just because we're a bit short on time, so maximum of 5 minutes, that's the maximum time. So great, thank you.
Yeah. As you know, the most important the treatment for the forest is antibiotic therapy, and there is no need for IVIG or corticosteroid in the treatment of forest. Corticosteroid not only doesn't help you in the treatment of forest, but also it can worsen the immunity of your patient, and also it can worsen your the patient's renal function, and thus we have to avoid steroids in the treatment of RS. And in the diagnosis in RS is mainly clinical, as you know. Tender erythrodermia, bola, squamation, especially when the squamation is with a scaled appearance, especially in friction zones and pre-artificial crust, positive blood culture for staphylococcal infection, and positive Nikolsky sign, all of them. And the most important other is absence of mucosal involvement in the 4S. And in irritant contact dermatitis, you have a history of repetitive or prolonged irritant contact with irritant materials, especially with a strong soap in the infant, and also saliva in the infant can help you to distinguish irritant contact dermatitis from other, and especially from 4S.
Thank you, Dr. Kalantari, for your brief and also amazing answer. So, and also again for joining us, thank you. So, because we're a bit low on time, I'm going to play you my favorite clip again. And after that, I will pass the microphone to my dear friend, Dr. Abdul Mohammadian, with the second case. If you have any questions, you can ask in the chat section. And after that, our professors will answer them in the chat.
Thanks, Dr. Bakhtiari. Before we start the second case, I just want to remind that IMA considers recruiting members in education, research, IT, and events department. So if you want to join us, do not hesitate. You can contact us via email and website linked in the chat section. So shall we continue with the second case? Dr. Rahramanlu, please.
Hello, good morning. I'm Mahia Rahmalu, and it's a great pleasure to be with amazing Aima. I'm going to present an infant with hydronephrosis. Our patient was a 51-day male infant with a chief complaint of weak urinary stream. His previously he had 10 to 12 times of urination a day, but since 2 days ago it was decreased to 2 to 3 times a day. During this time, he had no chief complaint of fever or restlessness. There was no vomiting and no bad smell of urine was detected. He was born with the gestational age of 38 weeks and 3 days from natural vaginal delivery. His birth weight was 3,200 grams and his birth length was 50 centimeters on the percentile of 14%. His birth head circumference was 34 centimeters. He was birthed from non-consanguineous healthy parents with no significant family history of renal disorders. His mother didn't take any significant medications during her pregnancy except routine vitamins and complements. At the time of admission, he was 4,900 grams with head circumference of 38 centimeters, and his length was 56 centimeters on the line of 6%. His blood pressure was 90/50 with pulse rate of 100 and respiratory rate of 30. His temperature was 36.8 Celsius degrees. There was no signs of dehydration on physical examinations. We didn't detect any anomaly of face or limbs, and he didn't have any syndromic face. There was no skin tag or dimple. His heart sounds were detected with normal S1 and S2 with no murmur. On the auscultation of respiratory, there was no abnormal sound and it was clear. And while examining his abdomen, the belly was firm with no mass or organomegaly in deep touch. There wasn't any peripheral edema on extremities. During routine perinatal care at the age of 18, at the gestational age of 18 weeks and 3 days, he had a sonogram which reported an epidiameter of pelvis on both kidneys with 5 millimeters. And in the following sonogram, at the age of 24 weeks and 2 days, right kidney's epidiameter of pelvis was 9 millimeters, and the one of left kidney was reported 10.5 millimeters. And at this time, the amniotic fluid index was 14.2 centimeters. In this regard, after his birth at the age of 3 days old, and another sonogram was done in which moderate hydronephrosis of right kidney was reported. The right kidney size was 47 millimeters with AP diameter of pelvis as 11 millimeters and cortex diameter of 4.5 millimeters. Also, mild hydronephrosis of left kidney was reported with left kidney size of 52 millimeters and AP diameter and cortex diameter of 3.5 millimeter, and the AP diameter of pelvis was reported 8 millimeter. There was decreased cortical diameter in both kidneys. At this time, there wasn't prescribed any medications or any further workups. And later, on the age of 45 days old, a new sonogram was done in which a severe hydronephrosis of right kidney with the right kidney size of 59 millimeter and the AP diameter of pelvic reported at 28 as 28 millimeters. Also, cortical diameter of right kidney was 3 millimeters. On the other hand, moderate hydronephrosis of left kidney was reported. The left kidney size was 66 millimeter, diameter of AP diameter of pelvis was 11 millimeters, and the cortex diameter was reported as 8 millimeters. There was decreased cortical diameter in both kidneys. At this time, there was an echogenic 4 millimeter shadow in inferior calyx of left kidney, remarkable as a renal stone. So our patient was admitted in our hospital with the impression of antenatal hydronephrosis. We took laboratory tests and we prescribed prophylactic antibiotic. Urine output was charted and it was about 1 cc per kilogram per hour. A new sonogram was done in our hospital and avoiding cystourethrogram was planned. At the date of admission, you can see the laboratory tests and we had a normal urine analysis and the CBC, the white blood cells count was 7.8 and hemoglobin of 8.9 and platelets as 212,000. The BUN blood urea nitrogen was 5 with creatinine of 0.4. After 48 hours, the urine culture reported negative. At the sonogram, which was done in our hospital, the right kidney size was 72 millimeters with AP diameter of pelvis 28 millimeters with severe hydronephrosis. And the left kidney size was 67 millimeters with pelvis AP diameter reported as 11 millimeters with severe hydronephrosis. In this regard, we planned a voiding cystourethrogram in which a posterior urethral valve was reported. And we planned an urological consult. Based on whatever demonstrated here, our patient was a 51 days male infant with weak urinary stream and antenatal hydronephrosis with normal physical examinations. Severe hydronephrosis in both kidneys was reported and we had normal laboratory data. And a posterior urethral valve in voiding cystourethrogram was reported. Thanks for hearing me. I'm here for further questions.
Thanks, appreciated for your presentation. It is my privilege and honor to be participating the first ever English section of morning report, which was Science I Came.
Dr. Mustafa, I believe we do not have your sound.
It is my privilege and honor to be participating first forever English section of morning report at Children's Medical Center. Since I came here in Iran, it was being held in Persian, so I suffered a lot. Actually, I will head presenting or reporting what care we provided our patient. The patient really has been admitted in a nephrology ward where she is currently receiving all medical attention and care she needs or requires. Our first task was following the admission of the patient. It was to confirm whether our patient have a normal urine output or she is anuric. So to achieve that, we just start collecting his urine output and documenting it and calculating by a milliliter per kilogram per hour. And the second step was to determine whether the patient has hydronephrosis or not. If he has hydronephrosis, the level, the grade, and the severity of hydronephrosis. We assisted evaluated the patient by using of ultrasound sonography to see the size of the renal pelvis, the location of obstruction, and the wall thickness of the urinary bladder. And actually, it has been reported and has been mentioned by my colleague earlier. And our third step was to see if there is a renal impairment for this patient. And to achieve this, we have collected blood samples and urine sample and sent it a laboratory to measure both blood urine nitrogen, level of creatinine, along with inflammatory markers, electrolytes, urine analysis or examination, and lastly, urine culture. Eventually, because the patient's urine culture did not demonstrate any sign of the bacterial growth in the first 48 hours, then we succeeded conducting of the 14 cystourogram, which is actually has been reported normally. So I would like to talk about the differential diagnosis or the conditions which are known to cause of antenatal hydronephrosis. My dear professor, the condition which is known to be associated to cause antenatal hydronephrosis, they fall into two categories. The first category, which harbor the congenital obstructive uropathy. It is divided by a PETA, which is and he said or quoted like any condition that left untreated endangers renal function and impairs or causes growth potential. So they fall into two categories, and it has been divided according to the location or anatomic location of obstruction, whether the obstruction lies in the upper part. Okay, whether the obstruction lies the upper urinary tract obstruction tract or the lower urinary tract. If it is fall in the upper urinary tract, it is being associated a number. The most common cause is uretropelvic junction obstruction, which is the most frequent cause of hydronephrosis. The reported incidence exceeds more than 64% and followed by uretrophysical junction obstruction, which accounts 40% of the cases. The leading cause of the lower urinary tract obstruction is posterior urethral valve, followed by urethral atresia. And I will leave, or I will finish my comment here because the first case have been taken more time than what it was supposed to take it. And I will leave the section of the postnatal care to be addressed by dear neonatologist, Dr. Mirnia. And thanks, appreciated guys.
Thanks, Dr. Mustafa. Thanks, Dr. Kahramanlu, for your nice presentation. So I believe we have Dr. Mehtizadeh with us, our dear radiologist. So please help us with BCG, Dr. Mehtizadeh, if you have my voice. Professor Mehtizadeh, do you have my voice?
Hello, can you hear me?
Yes, hello.
Okay. I want to say that it's not a posterior valve case. Can we review the BCUG again? As you see, there's no reflux in this BCUG, and the urethra is normal completely. The bladder wall is normal. There's no irregularity in the bladder wall. And in the sonogram, you cannot present any hydronephrosis and hydroureter, especially hydroureter. So I think that it's not a case of posterior valve because no evidence of reflux and urethra appear normal. And according to patient's sonogram, bilateral UPJ obstruction is the most possible diagnosis. In this situation, the most important points are the AP diameter of renal pelvis and renal cortical thickness. The AP diameter less than 5 or equal than 5 millimeter present normal. And if it is between 5 and 10 millimeter, it's called mild hydronephrosis. And between 10 and 15 millimeter, it's moderate. hydronephrosis, and more than 50, it's severe hydronephrosis. And if renal cortex is lower than 5 millimeter and the AP diameter is more than 25 millimeter, we should decide for surgery. And before surgery, we should have a DTPA scan for rule out and confirm the severity of the stenosis. And I want to say that we should have a review in this case and decide about that it's bilateral UPJO stenosis or it's PUB. And I think it's bilateral UPJO stenosis.
Thank you so much. Actually, I was shocked because I was not expecting this. So before proceeding to the dear nephrology department, first I want to ask Dr. Mounia, our dear neonatologist, to tell us about the importance of neonatal screening and perinatal screening of kidney and urinary tract anomalies.
Good morning, everyone. I think in the antenatal period, if you have a sonography that is showing that AP pelvis is dilated and you have hydroureter dilation with the dilation of the bladder, then it's shown that you have a case that is maybe antenatal posterior urethral valve. So in such a cases, the most item what is very important for you is the hypoplasia of the lung. So if you have a hypoplasia of the lung, it's better that you deliver the baby as quickly as possible. But if you don't have any hypoplasia of the lung, well, it's controversial for interfering with the fetus because it's a very dangerous work. Well, we try to recommend that the baby is delivered in a third unit hospital, that we try to have it be available, that we have urologists over there. After they are delivered, the first work what we have to do, we have to have one urine culture and urine analysis. But before of this, I have to talk about the I think maybe you want to ask about the sounding the baby. Yes, or do you have any questions about that?
I didn't get that.
Well, you ask about the antenatal procedures. Well, I said to you that what we have to do. That do you want about the procedures of postnatal or not?
Let us just skip to the nephrology department because we are a little short on time, and later on we will have that discussion in the chat section. So thank you, Professor Mounia. Thank you so much. I want to ask Dr. Askarian about the best time to perform with DCUG, and of course their comments on the radiology comments, because I did not expect that. Dr. Askarian, if you have my voice.
Yeah. Good morning, everybody. Can you hear my voice?
Yes.
Okay. First of all, I want to thank you for inviting me to this meeting. We admitted these children because of the suspicion of PUV and his bilateral severe hydronephrosis. And I want to talk about the postnatal approach to the antenatal hydronephrosis first. Postnatal hydronephrosis is divided in three categories based on the anterior-posterior diameter of the renal pelvis and the degree of dilation of peripheral calyces. In the low-risk group, the AP diameter is between 10 to 15 millimeter, and the central calyces are dilated, but the other part of the kidneys are normal. And in the intermediate risk group, the AP diameter is more than 15 millimeter, but the peripheral calyces are dilated and parenchymal appearance and thickness are normal. And in the high-risk group, the AP diameter is again more than 15 millimeter, and peripheral calyces are dilated, but the parenchymal appearance and thickness are abnormal, and parenchymal thickness is reduced. So we should done VCUG and antibiotic prophylaxis for the high-risk group, but both of them are optional for this low-risk and intermediate risk group. for this patient, we done VCUG, but there is no reflux in any part of the in any kidneys. So we should done DTPA to rule out a severe uretropelvic junction obstruction. Yeah, I'm at service for you.
Thank you so much. I believe we have a case that we need to follow it up in our upcoming follow-up sections. So I'm a little short on time. I'm really sorry. We had a lot of questions for you, and I believe we will
ask in the
follow-up section. Thank you so much. Thanks, Dr. Mustafa, Dr. Kahramanlu for the case, and I gotta thank Professor Munia, Professor Asgharian, Professor Abbasi, and Professor Mehdizadeh. It wasn't possible if they were not helping us. So just a reminder, we will shoot pictures at the end of the session, so make sure to keep your cameras on and make yourself decent. And I'm going to pass the microphone to Professor Aghai.
Thank you very much. I would like also to thank all of our audiences and also all of our participants here, especially our dear residents here. I can see your enthusiasm and the talents that you have, and seeing all of these enthusiasm that you have, I believe the brighter days for the Iranian pediatrics is not so far. So thanks again for our audiences and also the professors that attended this session. If I may, I would like to speak in Farsi at the end of this session. خیلی از همتون ممنونم بچه‌ها. خیلی ممنونم. واقعا برنامه فوق‌العاده بود. مطمئنم که هم مشابه همچین برنامه‌ای خیلی سخت باید توی مملکت ما پیدا بشه. اون چیزی که هست همش استعداده، همش روشنایی آینده است. دیدن شماها باعث افتخار ماست به عنوان هیئت علمی. دیدن هیئت علمی هایی که اینقدر مستعد هستن و اینقدر علاقه‌مند به کارهای نو، اون هم باعث افتخار. قطب علمی اطفال کشور، مرکز طبی کودکان کاملا به ایده های نو اوپنه. آیما یک مجموعه است، یک مجموعه‌ای که متعلق به هیچ کس نیست و در این حال متعلق به همه است. درها و دروازه‌های این آینده روشن به روی همه بازم دعوتتون می‌کنیم که حتما بیاین. ایونت‌های بسیار جالبی در راهه با بودن این دوستان مستعد ما. من فکر می‌کنم در کوتاه مدت ما اولین برنامه رو بتونیم به صورت مشترک با یکی از دانشگاه‌های خارج کشور که یه جورایی سورپرایز خواهد بود انجام بدیم و انشالله همه رو از تاریخش مطلع خواهیم کرد. پس راه‌های تماس با آیما رو بلدیم. از این به بعد هم بیشتر از ما خواهید شنید. خیلی ممنونم و انشالله که روز خیلی خوبی داشته باشیم.
استاد آقای، فقط خواهش میکنم از همه بچه‌ها، همکارا، عزیزا، اساتید اگه میتونید تصاویرتون رو باز بکنید، یه عکس یادگاری از این روز تاریخی مرکز طبی بگیرید.
این عکس قراره بره روی سایت دیگه بچه‌ها. همه دوربینا رو روشن کنید که انشالله عکس هممون روی سایت باشه.
خب ما یه 30 ثانیه صبر میکنیم که هر کی میخواد به ما اضافه شه.
ویدیوها باز نمیشه. ویدیو باز نمیشه. میگن که باید هاست باز بکنه.
استاد زیایی عکس ما رو خوشگل‌تر کنی.
استاد مهدی‌زاده، من براتون درخواست فرستادم که اگه بشه تصویرتون رو باز بکنیم.
ولی هنوز باز نمیشه.
الان باز شد.
الان باز شد. خب با ماسک یا بدون ماسک؟
ترجیحاً حالا که همه تنها هستیم دیگه، همه با رعایت فاصله و ایزولیشن، لطفا ماسکاتون رو بردارین که با صورت‌ها ثبت بشیم دیگه.
خب شد تو ماتیک زدم.
خب اگر همه آماده هستیم 1 2 3 میگم، همه بگن سیب یا بگین کووید. 1 2 3. یه دقیقه صبر کنیم لطفا. یکی دیگه. 1 2 3. خیلی هم عالی. ممنون از همگی که شرکت کردید. خسته نباشید. میبینیمتون.
دکتر آقایی اگه هستن، من ببخشید که تلفنشون رو ریجکت کردم. دکتر آقایی هنوز هستین؟ خب بچه بیاین، من دیشب نشستم یک عالمه اسلاید خوب درست کردم که این لور لیم رو به شما نشون بدم بالاخره کجاست. آره مورنینگ انگلیسی. آره مورنینگ انگلیسی خیلی هم چیز جالب بود. بحثات چیده بودم واسه پوستیرویتال مثلا این پوستیرویتال نبود. نمیدونم کی اینو گذاشت کرد پی او وی. نه ریفلاکس داشت نه